Hello, my name is Andrea Guicci and the topic is Volatile Anesthetics versus Total Intravenous Anesthesia for Cardiac Surgery. Definition. Volatile anesthetic agents share the property of being liquid and room temperature but evaporate easily for administration via inhalation. All these agents share the property of being quite hydrophobic. Volatile inhaled anesthetic agents have cardioprotective effects which could improve clinical outcomes in patients undergoing coronary artery bypass graft. Anesthesia during CABH is typically induced with intravenous drugs alone, total intravenous anesthesia, or with a combination of volatile inhaled and intravenous agents. When volatile anesthetics are administered before, during, or after periods of organ ischemia, they exert protective effects on cells through multiple mechanics. Applications in medicine. Volatile anesthetics reduce the biomarkers of myocardial injury even if anesthetics are administered for a short period before ischemia. Moderately sized randomized controlled trials and consensus opinion had suggested that the use of volatile anesthetics during cardiac surgery and especially during CABH goal improve myocardial protection and reduce the risk of preoperative myocardial infarction, myocardial dysfunction, and death.
Hello, friends. Today we going see about total intravenous anesthesia, its advantages, disadvantages. Let's get on to the video. Total intravenous anesthesia or DIVA is defined as a technique of general anesthesia, giving solely by fore-route and in absence of all inhalational agents inducing nitrous oxide. Total intravenous anesthesia, DIVA, offers some important advantages over inhalation anesthetics, including rapid recovery with a minimal hangover and a low incidence of nausea and vomiting. DIVA may be the technique of choice for some operations. Drug of choice for total intravenous anesthesia is propofol and remifentanil. Remifentanil is an opioid agonist with rapid onset and peak effect with short duration. Propofol gives quick recovery because it produces inactive metabolites. So these two drugs are the drug of choice for DIVA. Advantages: less nausea and vomiting, better postoperative mood, less pain, no malignant hyperthermia trigger, doesn't require anesthesia machine, no green gas effect. Disadvantages: more setup required, possible propofol infusion syndrome. Setup: evaluate preoperative assessment, connect the monitors, choose the correct intravenous and analgesic agent, load appropriate dose, monitor the patient. Okay, guys, that's all for today. See y'all in another video. Please subscribe to our channel to get regular updates regarding anesthesia. Thanks for watching. Have a nice day.
Pros and cons. Pros: the ideal volatile anesthetic again. It is safe for all ages and in pregnancy. Non-metabolic, rapid onset and displacement. Safe for exposure to operating room personnel. Total intravenous anesthesia, reduction in the incidence of postoperative nausea and vomiting. More predictable and faster recovery, greater hemodynamic stability. Preservation of hypoxic pulmonary vasoconstriction, reduction of intracellular pressure, Cons: total intravenous anesthesia. It is not indicated in children as they have small veins and require intubation because they are susceptible to respiratory obstructions. Usually, adverse events related to anesthesia, allergic reactions, proven or suspected to anesthetic agents, and were attributed to antibiotics, muscle-relaxants, or hypnotic drugs that during surgery due to cardiogenic shock.
More and more people across the globe are suffering from airway diseases like asthma and chronic obstructive pulmonary disease, or COPD. If these patients need surgery requiring general anesthesia, their airway disease can complicate the process and change how quickly anesthesia takes effect and wears off. One common issue is that these patients experience what is called ventilation perfusion mismatch, where some lung regions may get enough air, but not enough blood flow, or vice versa. When this happens, it can change how the body processes different types of anesthetics. But so far, the details aren't clear. Now, a study has investigated whether anesthetic solubility, how easily the drug dissolves in blood, is important. In the study, an international group of anesthesiologists evaluated 2 inhalational anesthetics in pigs, using a drug called methacholine to constrict the airways and mimic the airway disease of an asthmatic or someone with COPD. The team tested desflurane, a volatile anesthetic with very low solubility, and isoflurane, which is more soluble. They measured the uptake and elimination of each drug before and during bronchoconstriction using micropore membrane inlet mass spectrometry. In this technique, the amount of anesthetic can be evaluated accurately and quickly with mass spectrometry using a small blood sample. The group found that both drugs were slower to be taken up and eliminated in pigs when their airways were constricted, but the effect was more severe with desflurane. For example, while peak uptake fell by less than a quarter in the isoflurane group, it dropped almost to half in the desflurane group. Similarly, elimination fell by just 8% in the pigs given isoflurane versus 46% in those given desflurane. The results still need to be confirmed in humans, but they suggest that less soluble drugs like desflurane are more affected by ventilation perfusion scatter, as can be seen in asthma or COPD. Such scattering slows down the onset of anesthesia, as well as the recovery from it, offsetting some of the advantages modern low-solubility anesthetics have.
Is applied in Ecuador. According to WHO data, v 2030, nearly 23.6 million people are projected to die of cardiovascular disease, primarily heart disease and stroke. Cardiovascular disease are the leading cause of death in Ecuador and the world.
There are numerous things that result in a patient needing to have heart surgery today, and that would include a problem with their coronary arteries, blockages of their coronary arteries. Then you have a huge category that's actually growing now where the valves either leak or they're too tight. The third category, although less common but still exists, in which patients have had congenital heart problems that they were born with, and now they've grown into adulthood, either having had them diagnosed late in adulthood or knowing that it was there but now needing to have something done about it. A fourth category would be electrical problems with the heart, in which there would be some conductivity problem or rapid heartbeat problem that would result in needing to have specialized studies done and then possible interventions. Traditionally, everybody knows about open heart surgery through what we call a sternotomy, where people, quote, have their chest cracked, which is the typical terminology for that, but basically it's dividing the breastbone, going through the middle of the sternum, to get access to the heart. And this has served physicians and patients very well for 30, 40 years. We have become more and more comfortable with doing the same types of procedures through smaller incisions. So we have begun a fairly comprehensive program where every patient that comes to our center is looked at initially for a minimally invasive approach, a small incision approach or a robotic approach, one of the two. And if they are candidates for that, then that's how we do them. If we can't do it that way, then of course we offer them and provide them the traditional approach, but every patient first is considered for a small incision and less invasive surgery. I do think it's important today, as we go forward, that patients understand that as we have emerging technologies that are rapidly coming at us, it's important to choose a hospital that has a team that is looking at that. The team is highly specialized and super specialized in the area of coronary bypass surgery or minimally invasive valve surgery. All those are teams of experts that share their particular area of expertise. I bring something to the table as a surgeon, the cardiologist brings something to the table as a surgeon, and then at the end of the day, we have the best plan for the patient with the current and emerging technologies. Probably only about 15 to 20% of centers in the country are routinely doing successful minimally invasive valve surgery, either aortic or mitral or closing holes in the heart or doing electrical work. We understand now that high volumes equate very much to high quality. The centers that are doing higher volumes and the centers that are developing this team approach and a comprehensive commitment to minimally invasive surgery and robotic surgery, utilizing those types of techniques, are the ones that are getting the best outcomes.
Conclusion. In conclusion, among patients undergoing elective coronary bypass surgery, anesthesia with a volatile agent does not produce significantly fewer deaths per year compared to intravenous anesthesia and trials, and meta-analysis did not show any benefit in other types of cardiac surgery or combined procedures. Thanks.